I just finished writing the 8-hour training course for ASAM, for the ASAM criteria with David Mealy, David Gasfriend. And for those of you who've used the ASAM criteria, you recognize that it was developed ultimately by David Mealy, started back in '85, has been through multiple iterations. And the version that we're using now is 2013. And that may seem like it's very old, but at the same time, the information hasn't really changed appreciably from the large-scale randomized controlled trials for placement into the levels of care. And it already was ahead of its time in talking about the use of medications and things like that back in the day, because again, this data has been there for a while. So we're going to go through the differences between the 6 dimensions, which are really at the core of what an ASAM criteria evaluation is. We want to make sure that we can develop a treatment plan, and then importantly, take that treatment plan and put them into the right place within care. And I think the biggest issue that we have to think about is the fact that if you put somebody in the wrong level of care, they're going to do worse. And more is not always better, right? So if you do this to where, yeah, it seems like it's coming from here. Can you guys hear back there? Is it even louder? All right, I'm just gonna keep talking. It's kind of my general approach anyway. So it's for everything. So disclosures, I have no pharma, no device, never taken a cent, and as much as I've beaten them up in these lawsuits, I'm pretty sure they're never going to reach out to me for a job. I actually have an investment portfolio that very specifically excludes all addiction stuff. So I had the people so that it doesn't touch any of the companies that are public or any of the products that are public or anything like that. So even in my mutual funds, it's scrubbed from all of that stuff, all right? And for people who actually prey on people. So I have no alcohol stocks. I have no, no stocks with, it's like getting louder. All right. So starting with the basics, I think the thing that has been very disheartening for me is as I train the general medical practice, right? The people in hospitals, the people that work in the outpatient setting on addiction in general, they don't understand generally the difference between screening, assessment, and level of care determination. So they think if they did like a NIDA quick screen, right? You know, in the last 6 months, if you had more than 5 drinks at one time or more than 14 drinks in a week, you know, if you used a substance, have you used a prescription for something other than prescribed, that they think that they've done the job. And somehow that equals addiction. But it doesn't, as we know. What that screens is for a risk of use. And then with that, you have to do an assessment. And what the assessment tells you is, 1, do they have the disease? And then 2, how severe is it? And then that allows us to then take that information and put it into what we would call the level of care determination. And the level of care determination that has the most data, and is really the only validated current tool, is the ASAM criteria. So that's the progress of how things are supposed to move through the system. Unfortunately, it skips around a lot. And what I have identified, and for those that do ASAM criteria assessments on a regular basis, everybody has their version of it, which invalidates the research when you come up with your own version. It's like if you have an assessment, but you kind of want to change a couple of questions because you don't like the way they wrote it, it completely invalidates the positive predictive value of that tool. So this is a real issue that we have to think about. And so the goal today is purely an overview, but there is an 8-hour version of this course that really drills down into the people who have to do these pieces. So the brief intervention piece, which we're not going to focus on, I pull it out only because a brief intervention very specifically is not for addiction. We do not do brief interventions on people with addiction. You can, it's probably not harmful, but it's not helpful. People who have risky use of a substance, however, it can be helpful, and the 2 substances that we find that it's very helpful are tobacco and alcohol. It doesn't seem to have any impact on opioid use if they have risky use of that. So the fact that you're doing SBIRT, screening, brief intervention, referral to treatment, I'm not sure how you're actually referring to the right level of treatment or to the right place for treatment if you haven't done an assessment, right? So it should be SABIRT, screening, assessment, brief intervention, referral to treatment. But you should only be really doing the brief intervention specifically on those that have risky use, or using that time as a motivational interviewing technique to get them to that next level of care as a main part of that intervention. Does that make sense? All right. How do we start these conversations? This is really important, and I think we forget this a lot. You know, you're using a lot of dope, it's bad for you. You should probably stop that. I don't know, that's not received well. You're hurting your baby. Also not helpful, right? These are things that we have to figure out how to have this interaction. And so when we're training people on how to do any interview technique, even if we're just reading from a standardized screening, right? So even if we're just reading from it word for word, you can do that in an empathetic way. You can pause, you can interact, you can ask permission to do this. And that's one of the bigger things is you want to really walk through and let them know that, no matter what the answers are, whatever, we're going to figure it out. We're on your side. We're part of your team. And in my office, we had a rule, we never fired anybody, period. And so in 5 years of treating the most, behaviorally significant people within a health system, because we got everybody's patient that they didn't want, whether they had addiction or not, they would say, they have addiction. And they'd send them to us and we would identify they didn't have addiction, but we'd still see them. So there were people who had written threatening letters. There were people who had, caused like physical harm to someone in the health system and they were looking at firing them from the health system. That was our standard, that was our average patient. And so when we interacted with them, of course, in our clinic, we never had any of those things happen because we were trauma informed. We reframed everything appropriately. But you have to understand that if they don't know that, then you're less likely to get accurate answers to tough questions. And so it's important for people to know that you got their back, and this is not a way for you to intervene on them in such a way that it's going to cause harm. So this training is a consolidated version of the ASAM training I've written. They gave me permission to use the stuff I wrote because it was written for ASAM to use it here. But again, it doesn't take the place of the full training wherever you get that. So if we look at the dimensions of assessment, this is just basically a good assessment, right? We should be doing this for pretty much everything that we look at. Maybe we don't have to look for withdrawal potential for someone, that we're evaluating for diabetes, but at the same time, all of these other pieces are things we really should understand if we want to have a good, effective, positive outcome. So when we look at these dimensions, dimension 1 is the most important quick thing that you need to know. Is this person going to go into withdrawal? And if so, where should they get treatment? Now we're about to have new alcohol withdrawal guidelines. We're just about finished writing those. We've gone through our last modality for this, and we've done deep dive definitions of what we should do for outpatient alcohol withdrawal as well as inpatient alcohol withdrawal, and we've written new guidelines for all of those. And it's actually not that benzo heavy, so we're moving away from benzodiazepines and more toward a lot of the other medications, so we have less controlled substances out in the community, and we can do more of the outpatient withdrawal management, which means you're going to have to learn a lot more in the ASAM criteria about not just the levels of care of where people get intervened, but the levels of withdrawal management, which is like level 1, level 2, and level 3 withdrawal management and where those go. But it starts with an evaluation before you get to. So that's one of the other things that I identify is people go, I think you need residential. And I'm like, how? Like, how are you making that decision? And most people don't even know that residential level 3.1 is actually the least intensive care we can give you. It has less hours of required intervention as compared to any other level of care. It just is a roof. So, in the end, they only have to give 5 hours of treatment clinical intervention per week, and it's not specified as to really what that is, and it has the lowest level of licensing requirement of any of them. I'm not saying it's not necessary, but I think that people just need to know that just being in a place doesn't necessarily mean you're getting intensive treatment. Partial hospitalization gives you the most intensive treatment, level 2.5. And we'll get into these, and you're going to hear these numbers over and over for those of you not understanding of the ASAM criteria. But this is no different than cardiac care. We just have different names for it. So if somebody shows up to a primary care office and says, I have chest pain, they're going to call, before they do anything, that screen is positive, right? That's a positive screen. I have chest pain. Fine, screen is positive. Now what I'm going to do is an assessment. That assessment generally takes place in the level of care most adept at answering the assessment, meaning if it's positive, we got to do something. So they send them to the emergency department. So when they get to the emergency department, just showing up to an emergency department is a positive screen. That means I now need to do an assessment. And that assessment entails for cardiac an EKG, an evaluation of a chemical called troponin, a physical exam. And then from the assessment and the outcome from that, I determine level of care. Do they need to go to a cath lab? Do they need to go to the ICU? Do they need to go here? Depending on what my interventions are. But the level of care is still not determined until I've determined what we need to do for the person. So if they're sick, but I don't have to put them on a cardizem drip, then they can probably just go to a step-down unit. They don't have to go to the ICU. So we have to first figure out, are they at risk? Do they have it? And if so, how severe is it? And what do we need to do for them? And then we figure out where within the hospital they go. So we already do this on a regular basis for all the diseases. We do it for diabetes and care, whether they have diabetic ketoacidosis versus just high blood sugar. We do this all the time. So it's not different. It just has different names. And we don't do this deep of an assessment. Unfortunately, we should, but we don't do this deep of an assessment as a general rule. The levels of care in the most basic form are 0.5, which is early intervention, and that's not just expert. So that's a beginning of it would be early intervention, meaning you've identified that there's risky behavior and we need to intervene before it becomes significant. That can also be someone who meets for a mild substance use disorder, but has all of the other pieces of their dimensions kind of in place, right? They have good recovery capital, they have the capability of a safe place to be, they have a job, they have a family, they have no other comorbid medical conditions. This is a person who we may just monitor and have that early intervention of conversation. One, outpatient treatment. This is not primary care, right? So people misinterpret level 1 as primary care. This is basically an outpatient setting where people show up for 3 to 6 hours per week to be evaluated and treated for the treatment of their addiction. So it's not just primary care. We seem to lump it in there, but at its core, it's really not that, unless you have an enhanced primary care setting, like an FQHC that has integrated case management, integrated behavioral health. So just being someone who writes a script doesn't make you a level 1 addiction treatment provider. So it's important to understand that. Now, you don't have to have all the services occur in a single location. So as long as they're coordinating with other services, they can be getting level 1 care, but it's just not all happening at one place. Does that make sense? So it's not location specific, it's activity specific in what we're doing and how we're applying it. So you can have a primary care doctor who's writing for buprenorphine for opioid use disorder as a member of the level 1 team, but just the service they're providing is not level 1 care. And that goes all the way through level 2, 2.1, 2.5, 3.1, 3.3, 3.5, blah, blah, blah. Level 2, intensive outpatient and partial hospitalization. Those are really just about the amount of clinical hours that you're delivering to the population. And that's how they break out. Generally, if you're a level 2.1, you can turn yourself into a level 2.5 as long as you have the right number of licensed individuals to deliver that care, and you can do that. It's just about the number of hours per week that you can manage to get done for a right number of patients. 3, residential. Again, we have level 3.1. Level 3.1 is the kind of the lowest level of care, but it has a roof and it's generally a kind of a recovery community feel to it. Level 3.3 is specialty care, those with like brain injury or other cognitive disorder issues. Those are very rare to find because they're highly specialized, and you'll find them generally only inside of a larger urban area. But you can also do 3.3 level care if you have 2 individuals trained to handle cognitively impaired people, and then you can bill for that. So there are ways to do that even in smaller communities, especially those that are delivering already 3.5 care, which is that higher level of care, more clinical hours per week. It's clinically monitored, and then you have 3.7, which is medically monitored, and then you have level 4, which is medically managed. So basically, you're just stepping up in the amount of doctor time as it goes, and as it goes up, because it means that you have more biomedical conditions that need to be evaluated, a higher risk of withdrawal complications, and that's the main rotating factor. Because as we've all seen, if you work in addiction, the physician becomes really important early, but then my role is pretty minor long term. I mean, my behavior team really takes over as the major providers of treatment for our patients after we've identified the psychiatric comorbidities, the medical comorbidities, and the withdrawal management phase, which is usually very early. That then goes down. So figuring out how we put all this stuff together becomes important, and that's what the ASAM criteria is really built to do. So one specialty level that we are pulling out is the opioid treatment services, and this would also be considered an OBOT as well, office-based opioid treatment. And what that means is that it's a clinic specialty designed to deliver medications for the treatment of opioid use disorder, and whether that's a methadone clinic. So in a perfect world, every, quote, methadone clinic or opioid treatment provider would also use buprenorphine and naltrexone in the same walls. We're getting there. And so I would say anybody in this room that is involved in the contracting of those services, next time you up your contract, you just have to add they have to use all meds. And if they can't, you put it back out for bid. I closed down 3 methadone clinics and opened 4 when I was the medical director of a regional PHP because they wouldn't add the services that we know they needed to add. The current ones, they just said, well, we don't think. I'm like, the data says. I kind of don't, like I said earlier, I don't care what you think. I kind of need it to be based in data. If you can show me research that says that that's not better to offer all of the medications that are FDA approved for patients with this, I realize it's complex because now you have categories of people that come to a clinic and it's not as homogenous, meaning everybody shows up and gets dosed every day versus some come in 2 times a week to get a script versus some get a shot once every 30 days and follow up for this. Lean process it, dude. This is not rocket science. We've managed to figure out how to do multiple things in a single setting in a lot of different places, so we just need to get there. And I'm finding that in addiction treatment services in general, we need more MBAs than MDs at this point because we need to make this service actually viable and consistent so that we can make it have a positive margin consistently so people can get trained, we can do QI, we can do all of these things that we need to do to be legitimate providers of medical treatment instead of shoestringing it from month to month and admission to admission. For a lot of the 3.1s, if they get 1 less admission, then they're having to dig into savings, and it's a pretty fragile industry when you look at all the players. All right, so the ASAM criteria decision process, like how do we actually make the decision before we really dig in? One, you do the screening, you do the assessment, and then we get into the level of care determination, and that starts with a dimensional analysis. So the dimensional analysis is a structured interview that talks about intoxication and withdrawal risk, biomedical conditions, emotional and behavioral, readiness to change, relapse potential, and recovery environment. Those are the 6 dimensions that we need to evaluate in order to build a treatment plan. If you skip one of those, it's not a complete treatment plan. From that treatment plan, we identify what are the services that need to be provided. We then apply those to the decision rules, and then we can decide what level of care somebody needs to go to. Does that make sense? Great. So if we were to look at the ASAM kind of decision rule matrix in its very simplified form, then if you have someone who is acute intoxication and they have no risk of that, then they can get care in the outpatient. Intensive outpatient, minimal, and it just goes up as their withdrawal risk goes up as well. And then biomedical conditions, again, if it's manageable, IOP, medical monitoring. And what you do is you check the box of each of these based on your assessment, and whatever hits the highest level of care is, generally speaking, the default location where we would like to put them. So if we have level 1, level 1, level 1, level 3, level 2, level 1, level 3 is where we need to get them because that's what we want to do, is identify where that is. But if you assess and it's all level 1, then they can bounce to level 1. Now the reality is that not every place has every level of care. So you have to default to levels of care that may be that. So the question always comes, do I default up or do I default down? And the short answer is, generally speaking, you can default down and you get better outcomes rather than defaulting up. And the reason being is because confinement, meaning residential, is typically more invasive than outpatient treatment, even if they're being seen on a regular basis on the outpatient side, and they have a tendency not to lose a job if they have it, not to have to figure out child care, not to have to figure out a lot of these other things that that make it really difficult for residential. And we're going to dig in. We're going to run a case from start to finish so that we can kind of see how this goes. But any questions about this? Now, granted, if it was that easy, everybody would do it right. The key is figuring out, how do you identify that this person has no risk of intoxication or withdrawal? What questions do you ask? What information do you need? What past history do you need to elicit? The hardest one is readiness to change. And the readiness to change, like, what questions do you ask? How do you ask those questions? Who should be asking those questions? How do you interpret the answers when they come back? And how do those answers then change the next question you're going to ask so you can get more information? I think you could see that somebody who's done this for 10 or 15 years is going to have a better chance of getting an accurate assessment of each of these boxes as compared to somebody fresh out, right? That can't be the way that we do this. We can't have the new person getting it totally different than the person who's done it. So we have to change it so we have inter-rater reliability that's pretty standardized, and we have people that are not fudging it based on the fact that they really feel comfortable with this treatment provider, but they don't really like this treatment provider. Right? Because how many times does that happen? You do an evaluation, you see a patient, you're like, it says this, but I like this person and the way that they do their work, and I think they'd be better there. So we usurp the entire process based on our own internal thoughts. That devalidates the entire process. So we have to recognize that that individual may have a better skill set or something that you want to do, and if you really do feel from your clinical judgment that that's the right thing, you need to explain that in the reasoning. And you need to put down, they originally met for this level of care, but I feel based on blank, blank, and blank that they would do better here, and in discussion with the patient, this is where we decided to go. That's fine. Clinical judgment is good a lot of times. But if it's a default judgment for almost all your clients, it's not fine. Right? So we have to, if I just sent everybody to cardiology, everybody to cardiology, everybody to cardiology, everybody to cath, then you have a lot of unintended consequences from that. So we have to do the same thing here. All right, so let's look at a case. So Stacy, 32-year-old white divorced female, been abstinent for 48 hours from alcohol and reports she's remained so for up to 72 hours during the past 3 months. So she's had 3 days of no alcohol over the last 3 months. When she has done this, she states she's experienced some sweats, some internal tremors and nausea, but has never hallucinated, never experienced delirium tremens or seizures. She smokes 3 to 4 joints a day, but stopped yesterday. All right, so how are we going to assess her for dimension 1? So if we look through this, what are the current intoxication withdrawal risks? That's, we have to assess that. So she's been drinking. When she stops, she feels like she goes into withdrawal, so we're going to have to address withdrawal because she has tolerance to alcohol, and so when that comes off, she's going to have a withdrawal syndrome, and we need to figure out what that is. Are intoxication management services needed? What do you guys think? Yeah, I mean, based on that, we're going to need some management of her withdrawal. Intoxication management. No, we don't need intoxication management. Maybe. So it depends on the time frame between I assessed her and then I had her follow up. So let's say it's a 5-day wait. You don't know if you need intoxication management services until she shows up. And that's just a reality. So if you have instant input, like in a hospital, you get admitted. You come in and you're sick. We're like, oh, you're sick. We're gonna keep you. And you're gonna sit in the ER for a couple hours while we're waiting on a bed, but we'll get you upstairs. For addiction, it's like, man, you're really sick. So in 6 weeks from now, we'll have a bed. And that's unfortunately what happens a lot, that delay. So this is a tough one to ask. But the big piece is if she has a risk, if you have that delay and she has a risk of continued drinking, which most of the time they'll tell you if they do or not, we have to come up with a safety plan for where she can be and what we can do for that interim until we can get into treatment. Significant risk of severe withdrawal, seizures, or other complications. And again, all withdrawal is made worse when other substances are also being withdrawn from. It's not a contraindication. In fact, the data is very clear that if someone smokes tobacco and drinks alcohol, that you should do withdrawal management for both of those at the exact same time. It improves your chances of maintaining sobriety by almost 40%. If you let them have smoke breaks and detox and withdrawal management, what they do is they rapidly increase the nicotine input, and then they come out more severely addicted to nicotine than they were when they entered, and it actually increases the chances for relapse to occur on alcohol as compared to not being on it. So I stopped paying for withdrawal management services that did not include a cessation of smoking. And if they didn't want to come in because they wanted to smoke, then the readiness for change score changed, and we would put them in IOP. I mean, they wouldn't not get treatment. We would offer them outpatient withdrawal management, but I don't want to waste money. We don't have that much. We have enough money to get those people that are ready for the level of care to push into that commitment. It doesn't mean we drop the rest of them off at the pond. It just means that we have to make sure that we come up with a less expensive, more probably effective management of that until we get them into the right place for readiness for change. That one hurt, by the way, when I did it. I felt actually bad because I looked at the data and we had 3,600 withdrawal management events for alcohol in our 3 withdrawal programs per year, but there were less than 500 people that had the withdrawal management. So there was a massive recidivism. And when we removed the smoking, and then we also put a marker on the number of times that someone could go through an inpatient withdrawal event before we would default to an outpatient withdrawal management pathway. We went to 3,700 events. So we increased the number of withdrawal management events in 1,800 people. So we more than tripled the bed availability for people who needed it. And then we decreased the recidivism significantly. And when we tracked that against ED visits and mortality in the county, we found no change in those. So in fact, we saw a decrease in the ED visitation because we had more people that we could get into treatment to do it. So it may feel icky to put restrictions on things, but when we just use the science and the data to figure out what we're going to do, that can be really helpful. So does she have current withdrawal signs? What are the scores derived? So we're going to use the CEWA scale. Now the CEWA scale, so you first have to define, do they have alcohol withdrawal? Then you can use the CEWA scale. You don't use the CEWA scale to define alcohol withdrawal. They may sound the same, but it's very different because maybe they're having a serotonin syndrome because they took a whole bunch of their SSRI and it looks a lot like alcohol withdrawal. And a CEWA is not going to tell me anything. So the first piece is you have to identify that they're actually having alcohol withdrawal. And you do that based on history and really having a conversation with the patient. And then you can determine the severity of that withdrawal using the tool, the CEWA. Looking at vital signs. Is she eligible for ambulatory withdrawal management? Like I say, we're going to have new guidelines for that are going to come out, and that's going to greatly increase the breadth of outpatient withdrawal management that we're going to be able to do. What about opioids? Withdrawal management for opioids. Should anybody actively withdraw from opioids? No, it's kind of ridiculous because you can just put them on bupe and they're done. That is treatment for both the withdrawal and treatment for the disease. It's the same with methadone. If they truly want to start on naltrexone and do that, then you may need to have a withdrawal event, but it's actually less severe and you can treat it with other medications that can be very helpful in that setting, lofloxacin and clonidine. So you can treat those things in other settings. So when you're doing the assessment, these become important that we don't default based on our history of what we thought they needed to get, but we really look at where we can get them. Lowest level of care that does the job. Stacy states she's in good health except for alcohol hepatitis, for which she was just released from the hospital a month ago. She was in the hospital for 72 hours and the stay was fuzzy, hence the 72-hour period where she didn't drink. It wasn't voluntarily not drinking, and it was a little fuzzy, which means she was either sick from her liver failure, or she was in a little bit of withdrawal, or they were giving her medications. It's hard to know. Records were not available from the distant hospital. Her doctor referred her for assessment to us. So this is not uncommon. We generally don't share well with others on the medical record side. Hopefully that changes with some of the Part 2 changes, but at this point it's tough to get records. So if we look at this, here are the questions that we would need to get at. Are there current physical illnesses other than withdrawal that we have to deal with? I mean, yeah, she's had liver failure. Does she have hypertension? Is it going to go complete wacko when we try to do a withdrawal event? Do we need to stabilize those first? We see this a lot with like COPD and an asthma-related illness or cardiac-related illness where people will have, these things are just not even stable yet. And so to try to attempt a significant withdrawal event is pretty dangerous. And so that changes the location of care based on that level of danger for that. Does she have a communicable disease present that could impact other patients or staff? Those are things that are important. The biggest one being TB. So if somebody has HIV or for any other reason they're on rheumatoid medication, their immune system is depleted, then they have tuberculosis. That can be communicable really fast, and it's really recalcitrant to treat, so that may change the location of care as well. Is she pregnant? I mean, pregnancy is a vital sign for me. Any birthing age female gets a pregnancy test in the emergency department. I don't care if you're here for an arm fracture, you get a pregnancy test. It's a vital sign. And so we have to make sure that we know what it is, because that does change direction and actually risk of services to be delivered, and sometimes urgency of services. And pregnancy history, especially if she has an opioid use disorder. The reason we say this is because withdrawal management gets very tricky, and that we don't want to have a significant withdrawal event in the last trimester. So as we go through, Stacy describes 2 past suicide attempts with sleeping pills. Sees a psychiatrist, takes Prozac, and then we have to look at emotional, behavioral, and cognitive conditions as we go through that. Right, so these are important. If we don't assess these, then we're not going to do it. I'm a proponent of every addiction treatment provider being co-occurring, because I rarely find people who are completely without a co-occurring disorder. whether it's caused by the addiction or just associated with or happened before, kind of doesn't matter at the early phases because it's still affecting them. Later on, it affects our pathway, but early on, it's that. And so we need to make sure that if they're connected, that all the subdiagnostic stuff, emotional, behavioral. So that means we're doing screening and assessment for these things in the setting of addiction assessment at the very beginning. And can they manage their own activities of daily living? Can they cope? Emotional, behavioral. I'm moving quickly because we got a late start and we're getting tight. So Stacy made it an appointment, showed up on time, but told her again and again, partner again. She had thought about quitting a lot of times in the past, but this is the first time she actually showed up. So that's significant, right? That shows that we've moved from pre-contemplation to contemplation, actually into preparatory phase. And some people you could even call this action phase. I would say I would wait one more step before I'd really call it action because you don't know some of the other factors that got her there. I don't tell them that because I want to give them all the praise in the world for making that big step to come in and do that. And thank you for being here. I'm so happy that we're able to help you. That becomes really important. She doesn't know much about addiction, but she wants to learn. That's always a good sign when they want to know more about the issue that they have rather than being either, I've had this for 10 years, I know everything there is to know, or whatever, just tell me what I got to do. Because then you have people that are just trying to check a box so that they get their paperwork done for their probie or somebody like that. And so this is, again, the readiness to change. How ready and willing is she? I mean, what would we say for Stacy? Does she seem pretty ready? Would we give her pretty good? Yeah, I would say pretty good. I wouldn't say she's, she has a plan, she knows what it is, she's done some research on what this stuff is, but she showed up. And many times that's the best we can do. I mean, I was always happy when patients, we weren't sure when they would show up. I mean, we were genuinely ecstatic when that would happen. Where is it? Oh, that's over there. Okay. I was like, okay. She does smoke 3 to 4 joints a day, but she stopped yesterday. Her last drink was 48 hours ago. She's managed only the 72 hours in the past 90. So this is the relapse risk. And this talks about, so she's smoking marijuana on a regular basis and she's doing these things. When we get into this, is her chance of relapse pretty big? Because the higher the chances of relapse, the more likely it is that we need to sequester her from locations of relapse capability. People, places, things. So that moves us more toward that residential treatment, depending on how high, she goes. And can they cope with the negative effects and the peer pressure around? This is a big one. We take the info chips out of the cell phones and crush them when they literally. I mean, that to me shows that they're fully in action phase. If they're willing to erase all the phone numbers in their phone, and they can choose who they want to reconnect with and get a phone number later. And then we have them change their phone number as well so that the dealers don't keep calling them and pinging them. She's got a son, he's 11, doesn't see any problems with her drinking and doesn't know about her marijuana use. Right. And ex-husband's not in the picture, current significant other is in and out, and she does have a car, but her license is suspended. So we shouldn't make committing a crime required for treatment. So when we say you have to drive here and do these things, we have to really be cognizant about coming up with another plan. And so the recovery environment, family affected, supportive friends, legal, vocational, regulatory, any transportation and child housing. Child care becomes the biggest one, and pet care, by the way. So child and pet care become an issue, and trying to make sure that we have a plan for that they have family members that they can trust. And they may have very low trust of family members, mainly because a lot of the trauma that they have from early life comes from those family members. They definitely don't want to hand off their kid to one of the same family members that created some trauma for them early on. So there's a lot of trepidation and fear that comes from that. So the treatment plan, we have to look at this. She's in withdrawal, nearing maximum tolerable time without relapse, which means we got to work on that ASAP. Her biomedical, she's got a recent hospitalization. She's got some comorbid depression, past suicide attempt, and now on fluoxetine, so she's being treated for it, but we definitely need to monitor that. Readiness to change, first time she made an appointment after hospitalization and told by her medical provider. So she was pushed to make the appointment and follow up, but she did. She did those things. And then relapse potential. Relapse is going to occur without a sense. I mean, it's just going to happen. There is no chance at not relapsing in the wild, so to speak. And then environment, little identified support. transportation barrier, usually overcome with bus pass, or we used Uber. I just got a credit card for the office, and we actually just used Uber. So when they're like, I want to come in, I was like, okay, where are you at? And we would Uber them in. Treatment plan. So she meets for residential treatment, level 3.7 admission with medical management for alcohol withdrawal and naltrexone induction for her alcohol use disorder. And then continue the fluoxetine, coordinate care with a psychiatrist, counsel for abstinence, her ex-sister-in-law to care for son during admission. And then we look at the continuing service. We need to reevaluate when she's ready to move on from that. And so there are criteria for us to actually look at, are they ready to move on and how do they move on, or do they stay? And then transfer discharge criteria, it's the same stuff. So these aren't things we have to make up. These are not things that we have to figure out or just like, you know what I feel, think, or want. We actually have some things that we can back into and take a look at what the data says is the best for the patient at the time. And I use this as a way to talk to the patient about where they should go for care, especially if they're pushing back, and we'll walk through some of this information. So addiction assessment requires an evaluation of all 6 of the dimensions, all 6. Can't just do a few. And treatment planning comes before the level of care. You have to be able to treatment plan before you do level of care. And then the idea of location of level of care, it may not be available. And so really think about whether or not you should go down or up. I think most of us default to up rather than down, but take a thoughtful approach to that, because there are unintended consequences to residential treatment for people who have any aspect of stability in their life that may go away if we put them somewhere for 30 days or 2 weeks or whatever. And engaging the patient in available levels of care is most important, meaning really have that patient-centered conversation around what that is. What's the next talk? So I realize that is probably the most rapid evaluation of an entire textbook that determines the entirety of treatment pathways for people. The big takeaways are there's a methodology. We know what it is, and in fact now we have Continuum. And Continuum is the online version of the ASAM criteria, and it has all of the structured questions and what we call an asymmetric branching methodology, so that if they answer question A this way, they get question B and C specifically for them. And it takes away that huge gap between those that have done this for 15 years and those that are just getting out. It also writes your note for you when you're finished. So it gives you a clinical narrative when it's done and is accepted by all the major payers as the billable level of care. That it's there. It still lets you change it if you want. It still says this is not the right level of care. And from a system standpoint, it actually allows you to create a dashboard of what percentage of the patients you've assessed in any given area meet for what level of care. So as from a standpoint of building a system and being working in a payer setting or anything like that, it lets you know what you need to build, what you need to contract, and how you fill those gaps. And that can be really, really helpful. So with that, I know we're out of time. And we have about 10 minutes from the other room, so that sounds about right. Yeah. And so I'm happy to stand up here and take any questions, but I already took away from one of your breaks. I don't want to be responsible for taking away from the next part. So hopefully this just gave a very quick overview and at least got everybody to understand that there is a place for people to go, and there's a way to define where that is and what should be delivered when they get there. So thank you.